Well, all right, folks. It is the beginning, the top of the hour. We have about 30 people with joining us today here. And I know that's going up quickly too, because I think we have maybe close to 60 folks who are interested. This is fabulous. So for those who didn't participate in the CPPS training, the CPHQ training that I have not had the pleasure of getting to meet, I'm Kim Workmeister. I'm the Senior Vice President for Improvement and Implementation at Convergence Health. I'm joined by my incredible colleague, Jen Wagner, who is our Director of Rural Health Initiatives. And so the two of us, you'll see us both kind of doing quite a few things during the session today. We intend to have this one and the one in 2 weeks be pretty interactive, which I know sometimes you think, oh, I just wanted to come in and watch a webinar, but when there's a little more interaction, it is a little more fun. We get to know what's going on. And the way that we're going to be doing that this time is through something called Mentimeter, which you may have used in the past. If you haven't, it's real simple. When we get to the first set of just a couple polling questions, I'm going to take my screen down. Jen's going to share her screen with the Mentimeter piece on it, and you'll get a link that's going to be in the chat box where you can click that link and it'll open up a separate window on your internet. It won't ruin anything with the Zoom here too. And so that way you can answer the questions or polls there. They're all anonymous. There is no wrong answer for anything that we're talking about today. It's really just a way for us to get to know kind of what the environment is like when it comes to root cause analysis and the safety culture that surrounds it then too. So welcome to the Foundations of Root Cause Analysis and the Role of Safety Culture workshop. We have about 90 minutes together today, and then the same thing in 2 weeks. We may or may not take the whole time, but I want to be sure that you have an opportunity to ask any questions that you want. Please use the chat box to enter anything in or to raise your hand if you'd like to just answer, ask a question in the middle. You please do not feel like you need to wait till the end to ask a question. Let's talk in the middle of it too. So please, I'm begging you to interrupt me because it's not an interruption. We can have a great conversation about this. So we're going to spend a little bit of time here. First, I wanted to make sure that I cover the accreditation statement and disclosure. The AHHA is so kind to be offering continuing education credits for this. You will receive this slide with the links in there too to the evaluation. I believe the evaluation, there'll be a link at the very end today that will come through. And of course that the evaluation is required. But it just need to make sure that you attend both sessions and complete the evaluations, and you will get CE credit, which is fabulous. So thank you so much to the Hospital Association. This is fabulous. So I want to start just with the basics here. Let's start with the anatomy of a root cause analysis. So there's some basic steps that we go through. We're going to identify and prioritize the event first when something happens, and the goal for that is to really just recognize and prioritize events that actually require root cause analysis due to the risk of potential harm. We'll talk about a lot more of this later. And there might be some tools that you utilize for that. Maybe there's a safety assessment code matrix. Maybe there's something else that you use to assess the severity or the frequency of events that are being utilized for the root cause analysis. Then you assemble your team. And the goal of that is assembling a multidisciplinary team that includes individuals with various expertise that's relevant to the event. But it can be a variety of folks too. And we're going to talk about the different types of makeup of root cause analysis teams. We'll get into that more in the second session, but just wanted to kind of put that in there a little bit there too. And there we might have some tools that talk about the best practice makeup of a root cause analysis team. Step 3, we're going to define the problem and collect some data, which is where we just really clearly outline the event details. Go through a flow chart of exactly what happened and when. We do an event timeline that tracks some key moments before, during, and after the incident. We are going to use interviews and witness statements. That sounds like such a, like a police officer. It's really not that, but we want to talk to folks who had any sort of interaction with the event. And we're also going to do a document review for what do our policies say about this, or procedures or other medical records. We're going to be looking through everything to gather the context that's needed for that. We're also going to identify, we'll walk through a very specific process to identify the root causes or the contributing factors to the event. And the goal of that is to determine the underlying factors that contributed to it. We're going to talk a bit, though, about what that might look like and why that might look different depending on the makeup of your root cause analysis team. There are some tools that we could utilize for those. One's called the 5 whys, one's called a fishbone diagram. We'll go through those, too. And step 5, you develop and you implement actionable solutions. So the goal is that we design solutions that actually address the identified root causes and prevent recurrence. It's not always done well. You will hear multiple times through this that's probably the most challenging aspect of root cause analysis, and that is creating an actionable action plan that could meaningfully make a difference the next time this type of event could potentially occur. There are some tools for that too to help. We'll send out something called a hierarchy of controls or a priority payoff matrix. There's lots of things to use there. Step 6, this part, I don't even like the way this is worded, but it is part of it. We assign accountability and develop an action plan. What that means is not assign accountability for the event, assign accountability for who's going to do what in the action plan. And how we're going to measure, coming up next in step 7, we need to measure and evaluate the outcomes or the effect of what we've put in place in our action plan. And then finally, we're going to communicate those findings and, very, very important, close the feedback loop. One of the most common statements about root cause analysis that we hear from teams, particularly in hospitals, particularly like frontline staff in hospitals, is they never hear anything again. They know that an event occurred. They know that there was an investigation. And unless they were part of, something where they had to redo some sort of training or they had to sign off on a new policy, there's no communication about what actually were the findings and what was done about it to help to prevent it and to help to keep our staff safe from having to be part of something like this again. So lots of those things that we are going to talk about as we move on. But first, what I want you to do is you can either use your cell phone, or I would recommend actually just using your browser. Jen's going to put into the chat box the link that you can click to get to this to the Mentimeter surveys here. So I'm watching the thing. Oh, there, she's already got it in there. I had it covered. That's my fault here. So I'm going to stop sharing my screen, and Jen is going to share hers, and then we'll go through just the very first one of these and see how this works for us. So I've stopped sharing. Jen, why don't you go ahead and share your screen for this? Oh, good. So everyone's you've already gotten to it. You're seeing the question. What is your experience with root cause analysis? Now, it is a little challenging to read the answers down here, but so it was either I've never participated in an RCA. We have a few folks like that. Fabulous. Good. I'm so glad you're here. I've only participated in RCA as a staff member. I've not led one. Lots of folks in that one. I've participated in one as a department lead, but haven't led the process. I'm now responsible for leading RCAs, but have not yet led one. Oh, my heart goes out to you, and you're in the right spot. We are going to help with that. And then a good portion of you have led at least one RCA. So for those of you that really have done this in the past too, this workshop is going to be a great opportunity for you to share with your peers what your experience has been like in the past too. Oh, and I'm gonna I think this is the next. Let me make sure I'm getting to my next call here. Okay, let me bring up my my screen so that folks can get that can get that code here too. I don't know why it's not letting me share my screen again, though. I may have realized that there are some things that I better do better next time. Okay, and let me switch my settings too. There we go. Let me take back. So if those of you that want to use your cell phone, you can see that. There you go. There's the QR code. So I'll give you a moment to get your phone out, because this will be the same QR code for all of the different questions that we have for today. All right. So welcome to the workshop. Can you all see my screen has gone black here? So I just want to make sure that you're all seeing.
Yep, we can see session 1, session 2.
Oh, okay, excellent. Okay, I don't know why it's not showing on the main one for me, but that is fine. Okay, so the goals for the series, session 1, we're going to go through the foundations of a safety culture. We're going to go through human factors engineering and the role of each in root cause analysis. And we're going to compare and contrast some different approaches to the RCA format. And then when we come back in 2 weeks, then we're going to go through more of the practical guide to of actually conducting an RCA. So today is more foundational, and then we're going to walk through some examples and say, what does this look like for you? What do you think about this one? And then too, and we'll start to think through, what could this example hospital have done a little differently, and how might you think through that? And then when you leave today, we're going to have 4 case studies that I'd like you just to briefly look over before we meet again. And we'll spend quite a bit of time on those then when we come back. So we'll go through the practical application of the RCA steps with using this real integrated safety culture lens for it. So I'm going to, let me make sure, see if I have, yeah, because I've got a couple more questions here. So I'm going to stop sharing, and I will do better next time. And I'll have Jen bring hers up so that we can start to answer. We can see how everyone else is doing answering these questions on how would you rate your organization's current safety culture. Again, this is anonymous. No fear of, there are no incorrect answers. So far, no one has said excellent, and that is not surprising. It is really, really, really challenging to have a safety culture that everyone in your organization would say is excellent. Good is fantastic. Needs improvement is not surprising at all. Even poor. So we're going to walk through some of these things that are so important to learn in the beginning here, to get in place before we start to do RCA. Even though we have, RCA feels like this whole separate process that we go through, unless we have the safety culture and the foundation of that behind us, we're not going to be able to have successful RCAs or effective RCAs too. So that's why we're spending a little bit more time with that today. Okay, excellent. So there's a lot of folks in here that are in the same boat here too, with a safety culture either needs improvement or is potentially even poor. So let's talk, we'll talk a little bit about how we can all work together to improve that. So why don't we go to the next question here? And that one is, how would you rate your organization's current safety culture? Excellent, good, neutral, needs improvement, or poor? And for some reason, I am not seeing, I'm just going to keep it up here. Jen, why don't you go ahead and share what you're seeing, what folks are seeing for the answers there. For some reason, it is not doing that today for me.
Sure thing. So I have us on the how frequently does your organization conduct RCAs? And we have quite a few only after major events, 16 after major events, 10 occasionally, 6 regularly, 7 regularly, and then none rarely, and then we have a few that aren't quite sure.
Okay, that's good then. So, and you know what, again, this is another one of those where there's not a wrong answer here. You might be in a teeny tiny organization that not a lot of things happen anyways. Great. And so maybe it is rare to have root cause analysis. You might be in a larger organization that uses a root cause analysis process as more of a quality improvement process. So you see maybe a trend and you go to the root cause analysis process for that, which is great. So maybe it's regular. Again, no wrong answer as long as your organization has a defined timeline for when do you do root cause analysis in your organization. Maybe it is just when a sentinel event or a significant adverse event happens, and maybe not. And again, that is okay either way. Let's go to the next one then. What is your primary goal when conducting an RCA? Is it identifying causes, assigning accountability, implementing solutions, preventing recurrence, or meeting compliance requirements? And Jen, I'll rely on you to let us know.
So we've got half of our group coming in, but the majority is the primary goal is to prevent reoccurrence. In their facilities, with 22 of our attendees choosing that one, and then 7 identifying causes, 3 meeting compliance requirements, and 1 to implement solutions.
Excellent.
And 0 on assigning accountability.
Okay, good. I like that. That's it. That is what I want to hear more than anything, because as long as we're not talking about assigning accountability for who's going to take care of the action plan. It's assigning accountability for whose fault it is when this happens. So that's something we want to make sure that we are not doing. And I'm thrilled that hasn't been the case. And frankly, these are all reasons aside from assigning accountability, but these are all really good reasons to do an RCA. The ultimate goal, I think, if you're moving along the priority list for patient safety, is preventing recurrence. But you can't prevent recurrence unless you can identify the causes, unless you implement solutions, unless you are meeting your compliance requirements. So again, no wrong answer on that. And then these are not in the survey here, but these are questions that I'm calling these questions to run on. Actually, let me make sure that I'm going back, because I just realized I'm not. Oh, why it's not letting me share my screen. So I think I'm gonna need to just go back, do this again. I think, Jen, I'm gonna forego these questions here, because I think it's causing too much of a I'm not able to get into them. So my apologies, folks. I'll fix that before we meet next time. And then make sure that folks can see my. There. Okay. I won't stop anymore. How about that? Except I'll turn off that part. Okay, so questions to run on, things that I want you to be thinking about as we're talking then here too. So what do you believe are the biggest barriers to building and maintaining a strong safety culture in your organization? Think of a recent RCA in your organization that was conducted. What was one positive outcome or challenge that you encountered? And we'll talk about these, later on during this too. How would you describe the impact of safety culture on your organization's patient outcomes, particularly for those who responded that your safety culture is poor or needs improvement? What kind of effect do you think that's had on patient outcomes too? And then also, what resources or support do you think would help to strengthen RCA practices in your organization? So these are things that we will be talking through here as we keep going. And I'm just gonna forego the rest of the survey questions. So first things first. So we need to start with the foundation here. As I said, we're here for an RCA workshop, but we need to build that foundation around our RCA that is our foundation of a safety culture. That a safety culture really is a precondition for safety, for learning from errors, for preventing new errors from occurring. And there's kind of this, I don't know what I would call it, but this universe around adverse events that helps to provide either safety, or if they're not implemented well or not well understood, creates an environment for adverse events to more easily occur. So when we talk about safety culture, this is really that sort of foundational approach that helps us to distinguish between human error, at risk, reckless behavior. We'll talk a little bit more about that. That helps to build guardrails around everything that we do in a hospital setting too. So let me talk through some of these things here. When we talk about values as a guardrail for safety culture, that's a commitment to safety. That's a foundational value that influences all organizational decisions and actions, the promotion of patient-centered care, prioritizing safety and well-being, and respect for principles, transparency in everything that we do. We talk about rules and procedures. I was like, oh, okay. But rules and procedures are necessary. Clear, accessible safety policies and procedures that are well communicated and regularly reviewed, and not just make sure you sign the new policy in the break room, but we really talk through, and why is this a policy? Was this put in place as a result of a safety risk that was identified, and this is how we're approaching it. That we must have standardized protocols for high-risk activities that minimizes variability, reduces the potential for errors, with an emphasis then on this adherence to procedures, but with flexibility for updates. So it's not a strict, you absolutely have to adhere to everything. We understand that particularly in healthcare and in highly reliable organizations, that we do actually have to be flexible. Sometimes the rules need to be a little bit changed as a result of what we're seeing in the environment too. And then leadership too. Leadership is we always know leadership is the key piece of this, but leaders need to visibly support and prioritize safety. They need to set an example for all team members. They need to encourage open discussion of safety concerns. I don't know how many of you have, hopefully all of you have some sort of process for huddles where your organizational leadership hears from team members who are actually working in all of the processes that we're trying to improve, and finds out from them and gives them the opportunity and the space and the encouragement to say, hey, this is a safety risk. I'm a little concerned about this, even before anything has happened too. That's what the kind of leadership that we absolutely need. And that's kind of information that leaders need to allocate resources appropriately to maintain safety. When we talk about communication, this is it will also part of the transparency piece of this too. We have to have open and honest communication at all levels of our organization. We have to have the ability to enable timely reporting of issues without fear of retribution. So again, that's the part of the safety culture there, that as a leader, we're okay with hearing that things aren't okay. And we use that, we actually embrace that and encourage being told those kinds of things so that we can help to create a safe environment. When we talk about teamwork and collaboration, that in a safety culture has this emphasis on the interdisciplinary teamwork and encouraging collaboration across the roles for comprehensive care. So, that means a mutual respect and understanding of each team member's contribution to patient safety. This is something I think we've gotten a lot better at over the years. It used to be that we thought, oh, well, the only people who really understand how to keep things safe are, the leaders in quality and patient safety, or other folks. I mean, think about what we know now for keeping patients safe from the transmission of C. diff from one room to another. The most important team members in our hospital are housekeeping services for them, right? And thank goodness they're here. They're fabulous members of our team that help us to keep everybody safe. Also promoting psychological safety, where team members feel comfortable voicing concerns and ideas, no matter what their role is too. And if you participated in either the CPHQ or CPPS, you've heard me tell a story multiple times about my husband being in the Navy, and that, how our military provides psychological safety for 19-year-old kids who are doing some really dangerous things, but they know unless there is the ability to speak up when something's not right, they're all going to be in trouble. So we try to utilize that in the healthcare settings too. Learning and continuous improvement is also a way of looking at root cause analysis as a way of building our safety culture. We have learned from something that happened. We were able, because we learned, we took a deep dive into what happened, and we created an action plan with guardrails to try to prevent it from happening again or something similar from happening again. And then we have this feedback loop. So the entire organization is able to learn from it without blaming individuals. It's here, we've all gotten updates, and we all know what happened, the reasons, the systemic reasons behind what happened, and then what we've done to prevent them from happening again. And then finally, accountability and just culture. We're going to talk a little bit about just culture, but this is that we want to ensure that there's clear expectations for individual and system accountability. What do I mean by that? That, any of you that are parents know that when your kids get to be teenagers, it's really, I don't know, it's really easy. I raised 4 kids, but I will say it was easier when they were little to say, this is the rule. Nope, these are the rules. You have to keep it in there. But then as they get older and they have gained their own personality and worldviews, and in the teenage years, there you see a lot of parents say, well, I guess I don't make as many rules. I don't think any of us say that, but there's a struggle with how strict do I get with things? How much do I need to do? And I will tell you, after spending a few years as a nursing director for a child and adolescent psychiatric unit, learned adolescents need guardrails. They want that structure and those clear expectations. The same, not that everyone in our organizations are adolescents, but the same rule applies there. We all need clear expectations for our own accountability too. And that helps to foster that balance of responsibility and support there too. We should be using a just culture, or that type of algorithm that differentiates between human error, at-risk behavior, and reckless behavior to guide our response as leaders to an event when it occurs. And we have to have an emphasis on improvement rather than punishment, except in cases of willful negligence, which they are few and far between, but there is a role for that. And we'll talk about that so that we can maintain trust in here. So that's safety culture. Those are all the components of safety culture. What is the connection then between safety culture and its influence on the success of RCA initiatives? And so I'll go through, there's a bunch of pieces of the pie here too that help that showcase how safety culture is an influence on the success of your root cause analysis. So when we talk about transparency, this is that we need to encourage it by promoting open communication about potential risks, near misses, errors without fear of punishment. The impact on the RCA is that transparency ensures that all relevant information is accessible during the RCA. It allows the teams to identify the true root causes rather than surface level issues. And the staff feel comfortable reporting minor errors, knowing that it helps prevent future issues and contributes to safer patient care. We talk about accountability then too. Everyone from frontline staff to leadership is accountable for upholding safety standards then too. And this balance, there's a balance here too between individual and system accountability here, recognizing that errors are many times, if not most times, system driven. So accountability here helps your RCA team to focus on systemic improvements rather than blaming individuals. When we talk about learning over blaming, that we have an emphasis on learning. We're prioritizing learning from incidences, near misses, again, rather than assigning blame. Leadership support and commitment, we've already talked about that strong leadership commitment ensures that the RCA recommendations are prioritized and followed through. That means that everyone has to be aware of them too. And of course, we've talked about psychological safety here too, that when staff feel psychologically safe, they're more likely to provide honest feedback during the RCA that reveals deeper insights into those systemic issues that we are trying to improve. And then we have to go through that continuous improvement and adaptation. So that means maybe there's something that is working, but yet there's one piece of that system that isn't quite. So can we adapt it? It doesn't mean we have to throw everything out and start over again. that's part of what continuous improvement really looks like too. So this one, I'm not going to take us to the thing here too, but maybe if you feel comfortable, if you feel so led, maybe enter in the chat box then too. So which component of safety culture do you think has the biggest impact on improving patient safety outcomes? And there's no wrong answer in this one either. Just be interested to hear what folks think about this. I'm seeing accountability. Yes. Anybody else? Mhm. All right. Communication, B&E. Yes. I mean, honestly, you could see how every one of these could potentially be number one. I mean, again, there just isn't a wrong answer. And the key here is to see, well, which of these components of safety culture are weaker in my organization? And those are the ones you'll want to prioritize to improve prior to improving your root cause analysis process here too. Thank you. Thank you for participating, folks. This one, I don't know if anyone would be willing to unmute your line and share, or you can type it in the chat box. Can you share an example of how safety culture, good or bad, influenced a positive or challenging experience in your hospital? While you're thinking, I'll give you an example. You might have heard this one before too, but many, many years ago, I was a quality director at a hospital. We had a significant medication error that occurred in the ICU. A nurse gave too much medication to a patient who required additional treatment as a result. And initially, the nursing director for the ICU came to me and said, "We have to write this nurse up. I cannot believe that she made this error. This is all her fault." And so my action plan is to write her up and send this to HR. And I said, "Whoa, hold on." There were many of us that said that. So what we were able to do is find out, okay, in the ICU, what had occurred that day is that this was a nurse who had two very, very critically ill patients, one of whom could have been a one-to-one instead of having one nurse and two patients. The entire unit was busy. It's a big open unit that was very, very loud and distracting. And the hospital, to save money on our medication costs, had started ordering the medication that had too much had been given of in large multi-dose vials. That meant that the nurses had to draw up just the amount of medication that was necessary for the patient. This nurse, in the midst of all of this chaos, drew up too much medication and gave that to the patient, and then realized once the patient started to decompensate her error. A safety culture then, what we were able to do and take that every unit of a hospital has a different safety culture. And we learned that our ICU did not have a great safety culture, even though we'd been working on that in other areas of the hospital. This became an opportunity for us to get to work and mentor this nursing director to learn about safety culture, to learn about human factors, to learn about all of the other systems level issues that contribute that did contribute to this medication error. And in doing so, then we were able to work with the organization, work with the pharmacy. We're able to show that this is a use case that saving money in this area resulted in money needing to be spent. And of course, more importantly, that a cost to the patient's health. So they actually stopped ordering that medication in large multi-dose vials and went back to the single dose use vials for it too. So that's just one example of it there too. How about, does anyone else have anything that you've thought of that you would be willing to share? Okay.
I was just going to add that sometimes if cases aren't reviewed and staff go home thinking, I made this error, I can't believe I did this, maybe I shouldn't be doing this. If without a review in a safe culture to
Yes.
realize how complicated their jobs are, they
Mhm.
go home feeling like it is their fault.
Oh, that's such a good point too. I think you could find examples like that over and over and over again in healthcare too. None of us went into healthcare to hurt people or to make mistakes. And you're right. How many of our folks do go home thinking, oh, I think I did something, because no one did this kind of review. And I think that's a good reminder too, when you think about, oh my gosh, we have to do a root cause analysis. It's so much work. There's so many pieces to it. I have to talk to so many people. This is why we do it though, too, so that we can support our staff members who were involved in this. And they just so happen to be the ones who are visibly involved. But we know that there's lots of other factors and lots of other people along the way who had some sort of involvement too. So thank you. That's a really good example.
I will add to that I have been in a number of root cause analysis where staff were at first very nervous, uncomfortable, wasn't sure what it was going to look like. And after told me how supported they felt by the process, how they were really uncomfortable beforehand. And as was just said, I've had staff tell me that they thought they were to quote unquote blame, and they had worried they were going to get in trouble. And just so many worries relieved by talking about it in a constructive manner as a group, and looking at what the underlying causes were and how we could address that and prevent it from happening again.
Oh, I love that. Yes. See, I knew you all are. I already got to know many of you through the last set of things. This is such a wonderful change in the way that we think about these events and the way that we think about our team members in our organizations too. We want to support them. We don't want anyone walking away. I mean, except in the very, very, very tiny percentage of folks who apparently did go to work with the intent to do harm. That's not what we're talking about here. None of these folks woke up that day or that evening and said, I want to make sure that I make a med error. I want to make sure I participate in contributing to an adverse event. Of course not. So this is just really indicative of how far your safety culture has come, that you've been able to, this is the thinking now too. This is good.
And I think it's wonderful because exactly what was mentioned many, many, many moons ago when I was a CVICU nurse, had a real sick patient, had to make a judgment call because I couldn't get a doc in there. They all had people on pump. And exactly what you said, the culture of safety was different back then. I actually finished my shift, wrote my resignation, and had every intention of walking away from nursing because I thought I had caused this patient harm. He lived, but it was just, I was so appalled at the mistake. And thank goodness they did do a root cause. And there were so many other things that contributed to it. It really helped me, I guess, re-engage.
Yeah. Oh gosh.
Because I did.
wanna
I owned
tear
it.
up.
Yeah.
It's so important. And I don't even want you to answer this question here. I just want you to be thinking about it then too, because this is what we're getting at too. How often do you think that your team or your colleagues feel able to speak up about safety concerns without fear of retribution? Is it an always now, or is it very rarely? And I'm sure the answers are all over the place for this too. That's part of what we're getting at here too. Good, Jessica. I'm glad your area is A for sure. But that's why we're spending so much time on this safety culture piece before getting more into the actual, steps of the root cause analysis. It's really, really important that we never go into a root cause without understanding this part of it first. Especially if we're going to be leading it, if we're a department leader who where it occurred. So maybe you're not actually leading the root cause analysis, but to understand what's happening in your department and how all of the other systems in place contribute to it, and why it is so important and valuable for folks to feel like they can speak up then too. What do you think might be some barriers? Again, please just unmute your line. Some barriers to achieving a strong safety culture, especially for those of you that are in rural settings. How could we address them?
That is a really difficult
You might not know how to
thing.
address them. I'm sorry, go ahead.
It is a really difficult thing because I have lived in small rural settings, which is where I'm at right now. I've been in huge tertiary facilities in the big city, which was the CVICU. In rural settings, it's harder because everybody knows everybody. And I know that people are supposed to keep things confidential, but that is not reality, I'm sorry, in
Mhm.
rural settings. It's just not.
Yep.
And so I don't know what the answer is to this. I
How-
just
how-
know that
Mhm.
it is an issue.
It is. How about anyone else? What other barriers do you see to achieving a strong safety culture, whether it's in rural areas or not?
I don't work in a rural area, but I would say sometimes it is the busyness of everybody's job. Everyone is so busy, they might want to do the right thing, but it's
Mhm.
easier to just jump to a specific conclusion and move on and keep going.
Yes, you are correct too. And not for anything now. I mean, I don't know that anyone's ever fully staffed anymore. I don't know that, I mean, it just is, that's our new, no, I hate that term of that, our new normal here. Yes, that's a real barrier. So again, it's not folks trying to do the wrong thing. It's the environment in which we are. And we're going to talk about human factors in a little bit, and that fits right into it too.
I was going to share from my experience in rural Alaska and the place that I was at previous to here, lack of follow through. So if something were to happen and people would report and then there was no follow through,
Mhm. Mhm.
that really discouraged people from reporting anything because they just felt like it wasn't important enough, or maybe something happened, but then nothing changed. And so they got really frustrated with the process and they didn't trust the process.
That is so important too, that it truly, having this feedback loop for everyone, whether they were involved in it or not, some way to regularly communicate to the entire organization, hey, here's some changes that we've made. You don't need to tell everyone here's every single detail that occurred, but it's, hey, we identified a system level issue with this, and here's what we've done. And thank you so much to our teams that have helped to report these things. Just thanking them again, and giving just as much information as you can about it. Sometimes folks bring up safety concerns, and it's not something that you can fix right now either as a leader. It is just as important to say, thank you for bringing that to my attention. It is a priority for me to try to figure out how we can address this. I can't right now. I can't. And let me tell you why I can't. But it's on my, so even that is really critical to be able to say, because we can't fix everything, but we can be aware and see if there are certain things we can do to try to fix some of the challenges that have come up. So let's go on then to the other pieces of the foundation here too, and I'm going to talk about the human factors side with this precondition for safety, and that's really understanding human factors and the relationship that they have to events that occur, and why we need to consider those as part of our root cause analysis. So human factors, what that is, it's the study of how people interact with systems, environments, and processes, and with the aim of trying to improve performance and reduce errors. So in healthcare, or in any high stakes field, high consequence industry, human factors science or human factors engineering focuses on designing systems that align with human abilities and limitations to minimize errors and enhance patient safety. So there's no perfect human factors engineering process, but you'll start to understand why some of them are there and understand the limitations of them. So one of the ones that isn't as effective as others perhaps, but is still there, is in your EHR. If there is, you likely have many pages you have to go through in the EHR to document whatever's going on with your patient. And many of you probably have BPAs, or best practice alerts that come up based on information that's in the EHR. And those are intended to be a human factors engineering way of getting the human brain to stop what you're doing from rote and think about it and think, oh, okay, yeah, thank you. I don't have to memorize every single best practice. You're showing me this is something. However, if it's not designed well, we get too many of those. We get that alert fatigue. We get that override. And then it doesn't work. So there's also a science and an art to using those types of, that type of human factors engineering. There's a lot of others though, too. Some of the key principles of human factors engineering in healthcare would be the system design. So that's it. Human factors advocate designing systems, tools, and workflows that support safe and efficient work. We try to minimize complexity, so simplifying processes when possible to reduce what we call cognitive load or the need for memorization, so we can prevent errors that way too, especially under pressure, which I don't know that there's anything that happens in healthcare that isn't under pressure all the time. Also usability and ergonomics. So is your, I was with my husband in the ER a couple of months ago, and this struck out to me because the nurse said it too. And I thought, oh, we ought to look at the human factors engineering in here. She was giving, she was given an IM medication, but to get to the sharps container from where she had, it was like the whole room was configured really weird, so that she had to kind of just do pretzel, herself to give that medication and then get to where the sharps container was. And it's like, oh, this isn't good. And I could really easily see a nurse accidentally getting a needle stick from just having to maneuver around like that too. So that's another way of thinking about human factors engineering. And human factors have a role in adverse events because human error, not on purpose, human error is often a result of those poorly designed systems. When we talk about human errors too, there's really three types of them. So there's really simple like slips, like mistakes, lapses where you're forgetting steps, or rule-based mistakes where you're sort of misapplying knowledge. I'm supposed to do this, but in my head, I'm thinking of this and doing that. An unclear medication label could be one of these where it led to a nurse administering the wrong dosage. But this is a system error that human factors could address by improving the way that we label medication. So that's another way of thinking about it. And the other way that understanding human factors contributes to the root cause analysis is that we help to shift the focus from who to why or how to, and it helps us to know that we need to investigate the entire system design when we're doing that flow chart. We're figuring out exactly what happened step by step. It's not just these are all the things that happen, but here's all of the things that were coming in to contribute to it also. So some of the things that we think about when we're talking about human factors. So there's a few particular pieces of human factors. So person is one. Or do we have self-awareness? Are we fatigued? What does our workload look like? What is our situational awareness? And how does that get changed based on what's going on around us too? Their people is another component of it. Is there teamwork? Is there good communication? Is a leadership there to support the safety culture and the human factors around? Is there what kind of processes are in place? How are we managing our processes? Are we using checklists or bundles or guidelines and procedures? What kinds of are we using products that help to improve human factor or help to address human factor? So different kinds of equipment, technology, manual handling aids, those things. What is the environment like? And when we're talking about place, how loud is it? What is the lighting like? What does the layout and the space look like? And then the overall prevailing culture too. Again, culture is always going to wrap around anything else that's happening there. And that's at a local level, it's at an organizational level, and even at a societal level when we're talking about policy, regulation, those kinds of things. So if you're comfortable in answering in the chat box, which aspect of human factors do you think is the most challenging in your work setting? You might work in an office too, which is totally fine, because human factors is in every type of work setting. So what would you say is most challenging in your work setting? Is it the communication, workload, technology usability, environment layout, decision making under pressure? I'm seeing some A's, some C's, some D's. Yes, see, again, this is one, there's not a wrong answer. So this question is really to start to think through, okay, so if I know which one is most challenging, that's going to be the one we're going to prioritize when we're building an improved safety culture. in our work setting too, in the interest of preventing errors from occurring later on too. So I see across the gamut here too. Communication is going to come up all the time. Workload fatigue, technology usability is really one that over the past few years has become increasingly prevalent too as a human factors that's challenging. There's new technology all the time, and then with that new technology is this idea that the technology breaks down, or we think that technology was invented to prevent one type of error from occurring, but we didn't realize that technology now has created a new type of error that we have to be aware of too. So just it's a constant one of these, all of these constants. So again, I just put this here really so you can start to think through how to prioritize some human factors that are have a significant impact on the safety culture in your area. Does anyone have an example of how a human factor like communication or workload or any of those that you said this is the biggest issue has impacted an RCA or an investigation that you've conducted or been a part of? Or even if you weren't part of the RCA, was there a human factor that contributed to an event? And what was that?
Not like specifics, but many of the things that we come up with, I would say relate to communication. There's a lot of siloing. We have many, many departments because we have what, 48, no, how many village clinics? 48 village clinics.
Wow.
And then our facility here in Bethel, and there's a lot of services. And so with that being said, we tend to silo, and that is a huge problem here.
Yes. Yeah. Excellent. I mean, not excellent, that happens, but excellent example. Yes. Especially with that many clinics. My goodness. How about anyone else? Any other examples that you're willing to share? Okay. Well, again, that's really. Oh, go ahead. Sorry. Yeah.
No, I was just gonna say one hard part right now is our emergency department is under construction, and even before, kind of being in process, it's way too small for the population. So sometimes there are just physical restraints, so that creates
Yes.
really difficult barriers that you can't always fix easily.
Okay, that's a very good. I'm glad that you said that too, because some human factors we can't fix, we can't change. So what can start to think through then too? What are some things that we could put in place that could help to bolster the safety, knowing that human factor is going to exist no matter what there too. So really good examples here too. Thank you. All right, I'm gonna go on here. So what this here too, I'm not going to ask this one, but really just how familiar are you with them too? We're going to, when you, at the end of the 2 sessions, we have a root cause analysis toolkit too, that everyone will be able to use with a lot more detail about human factors and safety culture and all this too, with some foundational literature, some lots of different tools and things and resources too. So you can familiarize yourself with this. I mean, because just a couple hours here and there in a workshop isn't going to necessarily build up the entire body of knowledge for it too, but just being aware of this makes a big difference in outcomes and safety for the areas where you work then too. And so then I want you to start to think through, you don't have to answer this one today too, about what kinds of improvements then in system design or process do you think could reduce human error in your hospital? So again, going back to that, is there a something within a human factor type of example that can't be changed? So is there something different that we could do to reduce human error? And I'll give you an example of one of these. So I have the utmost honor of getting to be the chair of the PFAC, the Patient Family Advisory Council, for my local trauma center, just as a result of family members who received wonderful treatment there several years ago. And one of the things that they had us work on last year was just getting a patient view of the system design in a really, really busy emergency department, where they had started to see an increase in violence. They had started to see just a lot of bottlenecks. They had seen, I mean, just it's your typical really, really busy trauma center where there's long waits, there's not enough spots, not enough places. And so they went through a process to change up what the emergency department setup is like and what the experience is like moving through the emergency department there too. And so, and then they, on top of it, added a patient lens to it, asking a few of us to be part of a focus group to not only experience it, but then to help the staff think through how do we use communication then too, as part of the improvement in the system design and process to reduce the risk of error there too. Because there was also quite a bit of risk for error. So that was just, kind of some of those things where you just maybe ask people who aren't normally part of your organization or aren't part of your department. That different lens, that different set of eyes is always a way to tap into maybe some new ideas about improving the system design for you there too. So when we get to how human factors work and their role in the RCA, then too, I think we've probably covered most of this ad nauseum at this point now too. But some of the common, I wanted to just really briefly go through some of the really common human factors challenges in healthcare. So high workload and distractions, that's never going to go away. So how can we start to think about how to make life safer in that environment? Communication and handoffs, that is the age-old issue that we all have. And how can we start to improve the communication, especially when it comes to handoff? Our technology and devices, if you have a medication barcode system where the barcode doesn't work in certain areas of the hospital, the scanner doesn't work, okay, we got to rethink that then too, so we can do that. So just a few things to think about when we get into human factors and their role there too. I also then wanted to just spend a little bit of time, and some of you might already have this in place there too, but for those that maybe don't yet, how do we apply safety culture and human factors principles to the RCA investigation? And so here's where I want you to think about just culture, which is that's the name of a tactic that's used to identify through a standard process when human behavior is just an error, or if it's the result of some sort of purposeful action, whether that be at risk or truly reckless too. And so the purpose of looking at human behavior this way when you're doing a root cause analysis investigation is to really focus on fairness first. Again, no one wants to be just because you happen to be the visible person when a medication error occurred doesn't mean that it is completely your fault. There are a lot of things that happened here too, and we want to be fair about this when we're listening. So a just culture algorithm is going to guide your RCA team to approach errors with fairness, distinguishing between the human error, at risk, and reckless behavior. It helps your team to really evaluate whether an error arose from a system flaw or individual actions, and then it helps to support kind of this balanced perspective for it. And when you're going through a just culture algorithm, you're then going to start by classifying the behavior that you're seeing. The teams assess if the behavior was an unintentional human error, like a slip. Was it an at-risk behavior? Maybe someone took a shortcut. And sometimes those at-risk behaviors, we know that you always know, you know that you're doing it. You don't know if you don't believe that it's going to cause harm. So some of those examples that we heard earlier too about working in a very busy CVICU, and things are happening, you don't have a physician around. There was probably some at-risk behavior that occurred there, but it wasn't
yes.
to do it. Yes, exactly, Jessica. I mean, that's what we're getting at. So there are things that sometimes at-risk behavior happens. It doesn't mean that it's wrong or needs to be punished. And that's where we use some of these substitution tests. Would another nurse with the same training have done the same thing in the same example here too? And then we get down to the reckless behavior. This is someone who absolutely knows that what they're doing is incorrect and dangerous. They absolutely know that there is a massive risk in doing it, and they do it anyways. That's very different in a root cause analysis. Identifying reckless behavior in a root cause analysis is very, very different from human error and at-risk behavior. And the way that it's different is how we approach it. And at first, I just want to say, you know, so the reason that we use some of these human factors things, and you've seen the slides if you were in CPHQ or CPVS, so apologize for that, but really just think through what happens when an event occurs and the very first question asked by leadership is, who did this? As opposed to what happens if the first question by leadership is, how did this happen? It's very, very different. And we have to start with the how did this happen, not who did this. And we do that by using this just culture process then too, where we'll go through, this is just an example of the way that the algorithm works. How, you know, was it something very severe? Was it actually reckless behavior? Was it perhaps negligent, at risk, but did not intend for anything to happen? It was really trying to get through the challenging situation was there. Or was it just truly just I forgot, actually human error? And so there's different ways that we approach each one of those. If the behavior that resulted in this, whether or not it resulted in an event, actually it's just behavior on its own, is truly reckless behavior, that's when we do need to have some sort of punishment, accountability for it. That person should get written up, or perhaps, I don't know, worse than that. If we're talking about something in the midst of at risk, that's where coaching comes in. It's, hey, I understand that you were doing this. Tell me more about why, you know, what was happening in the unit. Tell me more about what was going on at the time, because myself as a leader, I want to make sure I can get in and say, okay, we got to fix this environment, this situation, so that our people don't have to use at-risk behavior. And if it's simply a result of human error, forgetting something, we're going to console that person. There's no blame at all in that one. That's something that was wrong in our system that meant that that person had to rely on memory or do, you know, too many steps in a process, things like that.
And I can tell you that's exactly what that situation was. We'd
Mhm,
gotten a
mhm.
new piece of equipment that everybody thought they had been very well trained on. But this was one of those situations where the gray
Mhm.
came up, and I got the lead charge nurse who'd been there for 20 years, and we both made a judgment call that my gut was screaming at me not to do.
Oh,
And so, yeah, that's when we realized it was truly this new piece of equipment, and we had not gotten the proper training from the surgeons.
how
So,
long ago did this
yeah.
occur? I'm really interested, Jessica. How many years ago would you say that this occurred?
Oh my goodness, more than 20 years ago. This was a turning moment in
Mhm,
I'd never made a med
mhm,
error.
mhm.
Like I said, I almost walked away from nursing.
You
And
know, that, go ahead.
yeah, I ended up being the ventricular assist device resource nurse and the heart
Oh,
transplant resource
oh.
nurse. But prior to that, I almost walked away from nursing all the way.
And that, okay, that right there, that's exactly what I want other people to hear, is that these situations, if we're not handling them in a way that understands the moral injury that our team members experience when they are involved in you know, an event, or you know, something that they didn't mean to, where they were just trying to do their job, just trying to take care of their patients, it sticks with people for the rest of their lives. And 20 years later, I can feel it in my gut still, that
Yep.
and that's why this is so important. So I'm wondering, from any of you, which do you think is the kind of behavior that's the most challenging to address under this just culture framework? Again, I don't think there's any wrong answer here, but is it most challenging to address human error? And by address, I mean to go in and take care of it, you know, or do something about it. At risk behavior, reckless, all are equally. I see B in here. Anyone else? I think I would agree with B too. Again, no wrong answer, but you know, you can see how the human error, you know, okay, that happens. We're going to go in and we all understand and know. it's that at-risk one, because it's so gray. And when you're trying to address it, you're talking to folks in healthcare, like, I'm just trying to do what I need to do to take care of what I'm supposed to do for my job. And there were all of these barriers and challenges in place. So I had to do something different, but I didn't think anything bad would occur as a result of it. There's so many pieces to that to try to fix as a leader too. So I think it's B, but I can see how every one of them it could be equally challenging though too. And so again, just food for thought as we're thinking through when we look at an example of a root cause analysis, and then when we really do it later on too. I'm not gonna this one. I'm just gonna let you think about then too when we come back next time too, but start to think about, when implementing just culture principles help to avoid blame and improve outcomes, and think about what the impact of that was. If you haven't been involved in it, you can probably guess it was a much better impact then to the overall safety. I'm going to go through because I want to make sure we spend more time here at the end here too. But what challenges do you face or have you faced in trying to apply these just culture principles consistently? If you've done it, not everyone has been a part of this, but if you've been a part, is there anyone that has been a part of using just culture as a way, as part of the review during the RCA process?
That's part of what we start with.
Mhm.
So we start with introducing, we are here specifically to look at our systems and our processes. It's part of our ground rules. This is not the place or the time for finger pointing or blame. That doesn't fix the problem. If problems arise during this process, those are dealt with during a different tract.
Mhm.
So this is not why we're here. And we truly do follow that.
Good.
If it comes
Good.
up with something, it may be referred to peer review committee, that kind of thing.
Yeah.
But we don't touch that in our RCA process.
That takes really solid leadership to continuously reiterate that that's what we're doing too. I appreciate that a lot, because I have been on the opposite side of that, trying to lead RCAs before we started this, this RCA squared process. We'll talk a little bit about that too. And we used to have to, the Joint Commission said, all right, you have this within, this many days, this many hours, everyone has to be at a table together. And I vividly remember being at a table with a surgeon and an OR nurse and a hospital C-suite person and myself and, a couple of other folks, and literal finger pointing happening. It was like, there's nothing in this process when it's set up like this that's going to be helpful. So thinking through then too, not only how you're applying just culture principles, how you verbalize then the expectations and the shared understanding of what the RCA process is like, and even who's at the table then too. Those, what I did learn through that is that when it's something like that, you never want to have the two people who were involved in it. And as human beings, as human nature, once you get in that situation, like, oh, people are going to blame me, so I'm going to blame someone else. We gotta, get past that. So have other folks at the table too. And perhaps you do individual interviews, perhaps, there's lots of ways to do it that encourages the continuous implementation of just culture principles there too.
Never
Okay.
really thought, I
Yeah.
had never really thought of saying, using that, defining that, I guess, as just culture. But, when we lay the groundwork and talk about the fact that everybody is equal, regardless of their title, because so frequently you do have such a wide range of people in there, from physicians to patient care techs, like if it's a fall or whatever the case may be.
Yes.
That I had not really thought of that from a just culture aspect, because it can be so intimidating. But yeah, leave your ego at the door and be respectful of everybody talking and giving them their
Yes.
chance. And
I
trying
think Meredith,
trying
I'm
to
so glad you
remember,
said that.
those physicians are so frequently afraid of,
Yeah.
the litigious aspect
Yes,
of everything.
absolutely.
So
Yes.
their anxiety comes out. But
Mhm.
yeah, I hadn't thought of that from a just culture perspective. So thank you for thinking of it.
Oh, no, I think that's excellent too. And you know, one of the things too that we've learned is to even improve upon that is outside of the room. If you have a C-suite leader or someone that's at a much higher authority level than the other folks at the table, privately ask them to not please don't be the first person to answer any questions. Let everyone else, as a matter of fact, ask them to ask folks who would be, you know, frontline folks, hey, I want to hear from you, and helping them, you know, coaching them too as leaders to build this safety culture, build this just culture environment too, where everyone has a voice, and you know, mimicking that by showing folks what that looks like too is really key too.
Yeah, I usually start with a person who has the least seniority, like say,
Yes.
tell me what happened from your
Mhm.
perspective so that
Mhm.
they can get their stuff out first.
Good. Yes. And you know what? That's what it takes too. That's what's being a good facilitator for these conversations means too. You understand the culture. You understand the environment and what's happening. You understand the politics that are just going to be in place because we're human beings too. And saying those things, setting it up that way is such a core piece to building an adequate and really effective RCA process. Oh, I'm so glad. These are great examples here. Okay,
You
we're gonna just
guys
spend the
gave
last few minutes.
me,
Oh, go ahead. Yeah,
oh,
yeah.
I'm sorry. You guys just gave me the best idea on the planet.
Oh,
I think one of the things that I'm going to start including in my RCA process is after introduction is done, with the ground rules, I'm going to take a basket and I'm going to hand it around and have everybody put their badge in it.
oh, I
And
love that.
then I'm going to explain why we're doing that and that we're all equals as human beings sitting at the table trying to discover, what is the problem.
I love that. I love that. Can you imagine that
Thank you guys.
visual and how
Yes,
that
thank
builds
you.
the feeling of safety? I love it. See, most of this is really psychology. Before, there's, of course, there's, the key clinical parts and all that, but it's a lot of psychology and building that safe environment for folks too. Okay, so let's just, I know we have like 15 minutes, so we'll just spend a little bit of time here before we get into, the real nitty gritty next time too, where we're just going to go through the process for everything. But it's really key to understand when an RCA should actually be done too. So first of all, your organization should have a policy. It may be the Sentinel event policy, maybe an adverse event policy, might be part of a patient safety policy, might be part of a provision of patient care. I mean, it could be in a bunch of different policies. So, or hopefully it's only in one though, because you don't want it in a bunch of different, because then you know what happens when you get surveyed and they see different language and for the same thing in different policies. That's a separate thing. But theoretically though, an overarching thing, an RCA should be implemented following what we call a Sentinel event. And for those of you that haven't been involved in these in the past, a Sentinel event is a really serious event. So it's a patient death, serious physical, psychological injury, something that's going to require additional care and treatment, something completely unexpected. When it's a Sentinel event, it's, oh my gosh, everyone says that. I love this one, after near misses with some sort of high risk that could have occurred. I love to hear when organizations are starting to use that have a strong enough safety culture to realize that those near misses are a gift to be able to learn from too. Again, a lot of organizations just don't have the resources, the personnel, the time to do a root cause analysis other than after a Sentinel event. And that understood completely. But if you could start to implement maybe a mini RCA, maybe not the full piece, but how can you start to use those near misses? If you have a culture that where folks feel safe enough to report them too, that's key number one there, to use those. I think those are the types of RCAs where we learn even more from, because folks get to feel like I'm part of a solution before anything even happened too. So another psychology piece there too. After seeing recurrent issues or patterns, Are you suddenly seeing a large increase in the number of catheter-associated UTIs in one unit? That's a good reason for an RCA. It doesn't mean that you're looking at one event and as soon as it happens, you're doing it, but you're using the process to better understand the system and not, not pointing fingers at people. So just a few of the, there's of course regulation or accreditation requirements around it. So depending on who your accrediting body, CMS also has some rules around never events, which is the same as a sentinel event, truly. And that you just have a process, a standard process in place that everyone in the organization should understand, but they don't always. That's our role as leaders, is to help everyone understand the process that we have in place. And again, it's going to be slightly different depending on your organization, but generally speaking, the procedure is you define the problem, you see this is what happened, you collect some data and evidence, you identify the contributing factors to it, you determine the root causes, which I'm going to tell you over and over again this time and next time that I'm not a fan of saying we found the root cause. Did you? And we'll go through why that's kind of, there's a lot of bias involved in there, but that's for the next session. You develop a list of actionable recommendations, and we're going to spend quite a bit of time on that too. What does it mean to create a meaningful action plan that actually has a chance of preventing this from happening again? So actionable recommendations and putting it into an action plan. And then when you implement those changes, ensuring there's a plan for monitoring it, and then documenting and reporting the findings. So, that's going back to our basic PDSA cycles. How do we know that a change was an improvement? We measure, we test, we measure, we see if it did what we thought it was going to be. And that's no different in root cause analysis than too. I'm not going to read all of these, but for those who aren't familiar, so there are a couple of schools of thought when we're talking about root cause analysis. And the old school, the old lady version for me was what we call traditional RCA. And that was, really only utilized as a retrospective analysis for sentinel events. We really did not use RCA as a way of looking at trends or anything like that, or near misses. We really kind of limited the scope of the investigation, to be honest, because we didn't really understand a lot about safety culture back then. And the follow-up was pretty inconsistent. I'm not going to say that that's still the case, but there's a chance of that too. And the investigation in the traditional old school way of doing RCA might not have been prioritized, could occur weeks after the event, which is, didn't have a dedicated team structure. There wasn't a set RCA team at the ready. RCA squared is another way of looking at it that it really focuses more on the system-based solutions, understanding the systems that were in place and allowed for an event or a near miss to occur. It spends a lot more time looking at the actions and using a hierarchy of actions to better assure that the changes that go in place from those actions are going to result in preventing that error from happening again too. And it just a lot more timely intervention. So they're just some of the, not for anyone to memorize, but just so there's some differences, and we will talk through those. And then, what I want you to be thinking through then too after today, before we come back next time, about, what would you like to strengthen about your organization's processes? We already heard some great ideas here too, which I love. And I just want you to be thinking about that too when we come back and we walk through all of these examples next time too. Do you want to strengthen your approach to investigation that uses just culture principles? Do you want to understand the actual structure? If you haven't done it before, or you haven't done it much, what specifically is the structure for it? What tools are available? There's lots of tools out there. No one should have to lead or participate in a root cause analysis from scratch and make it up as you go along. But there's so much out there. There's no reason for anyone to have to memorize any of this too. So I was just thinking about what is it that you would like to improve, and have that in mind. And I'm just going to spend a couple of minutes here on a case study based on what we've heard so far, knowing that we're not going to get into all of the details yet for the specific steps in it. But let's just see what you think about this hospital's root cause analysis. So the case study goes like this. There's a 72-year-old patient, Mrs. Smith, admitted to a rural hospital. She has symptoms of fever, chills, malaise, has a history of diabetes, hypertension. The hospital had very limited resources. Of course, it happens all the time, including smaller staff, fewer diagnostic tools compared to urban hospitals. And so on admission, she was initially diagnosed with a UTI. She was started on antibiotics. However, her condition did not improve. She began to exhibit signs of sepsis, including an increased heart rate, low blood pressure, some confusion. But due to the limited availability of diagnostic tests and specialist consultations, the diagnosis of sepsis was delayed. How many of our small, like critical access hospitals, small rural hospitals don't have point of care testing to get a lactate, to do things, this can absolutely happen anywhere. The outcome is that Mrs. Smith's condition deteriorated rapidly. She was eventually transferred to a larger urban hospital for intensive care. And despite aggressive treatment at that point, she suffered multiple organ failure. She had, severe septic shock and it passed away. Okay, so this organization was able to learn about what happened with their transferred patient, and they're going back to try to study and see, okay, so based on some of those basic steps of the root cause analysis, this is what the RCA found. So that problem statement, identifying the problem statement, they identified that it was a delayed diagnosis of sepsis that led to the patient's deterioration and eventual death. Data collection that they did for it. They reviewed the patient's medical record. They interviewed the healthcare providers and did an analysis of the hospital's diagnostic capabilities and protocols. And so the root causes that they identified were limited diagnostic resources, staffing shortages, and communication gaps. Based on that, their action plan was to enhance diagnostic capabilities by investing in point of care testing and telemedicine services, staff training, implementing regular training programs on early recognition and management of sepsis, and then improved communication protocols with transfer protocols with other tertiary hospitals too. Their implementation and monitoring plan acquire and implement the point of care testing. So what are you measuring of those action plans? Well, we're measuring this as a structural measure. Did we acquire new devices, new equipment? They set up a training program and they developed a new communication protocol for patient transfers. This is ensuring timely and efficient patient transfers. How do you think our case study hospital did? Is there anything in the findings, the actions that you think, maybe I would have done that a little different? Again, no wrong answer. Does anything stand out to you from this?
I don't think we got to the root cause yet.
That's exactly what I'm thinking. I mean, how likely is it in any of our organizations? Thank you. Where's the physician responsibility? Where is, where were all of the activities that occurred, if we're using a just culture algorithm?
Well, a sepsis bundle algorithm.
Sure. Yeah. Sepsis. Did we go through? Did we see any of those things? To have the initial root cause and then action be that they didn't have the right equipment. And so the action is, well, I guess the hospital's just going to have to pay for new equipment. I think if the hospital had the resources to buy that equipment, they would have done it. You would like to think that this would initially result in purses opening and getting funding for anything we need. That's probably not realistic. And thank you. No, too, you don't need a lactate to be suspicious of sepsis too. So there are probably some other systemic things in here that I don't see addressed in this one. This is, and this is just a really easy one here too. Of course they had training in there, but what we're going to talk about next time is, okay, it's one thing to say we set up training. And how many times have any of us been in a situation in a hospital where we have to do annual competency eval or something where you have to, okay, well, everyone has to watch the new video on the HealthStream video and you just go do through it. Is that really going to prevent something from happening again? I mean, I think they had good intentions, with that identification of the root causes and coming up with the actions, they're just not realistic or likely to be effective. So those are the things I want you to be thinking about before we come back next time. Because let's start to think through what should we have, what could we potentially else could we have identified or at least asked questions about for this scenario? No one asked what was going on? What else was going on in the unit at this time? No one asked what did staffing look like at the time? No one asked what is the skill level or skill kind of matrix of the staff that were there. What else was happening here that we should be considering within the system and understanding, truly understanding what happened here. So those are the things we'll talk about next time. You'll get these slides in a little bit too. I want to make sure that you have lots of access to different practical guidance. Jessica, go ahead. I see your hand raised.
Oh, yeah, I was going to say one of the things that I think has been helpful is if you go to the Joint Commission
Yes.
and look at any type of interventions that you find, they have them ranked. They will tell you if they feel this is a weak reaction to an event like this, if it's, medium, if it's a good type of intervention. And what you find, even though we know training always has to be part of it, it's a weak intervention. Policy changes are weak interventions. And so I think that's been very helpful. Putting those up on the wall when we get to the action planning phase.
Yes. Okay. And one thing that you'll get as part of the toolkit at the end here too is that hierarchy of interventions. That's probably what you're referring to on the Joint Commission. I think each one it does it, but there's a hierarchy of interventions where you can look and see, okay, what's the highest likelihood of actually preventing something from happening again, and what's kind of the lowest level version too. And we want to make sure that we're not prioritizing the lower level. Like you said, there's always going to need to be some education, but that can't be it. That can't be the only thing. So next, I know we just have a couple minutes left. So the next session, we're going to deepen our understanding of the RCA squared processes. We're going to do some practical application and emphasize the integration of RCA squared and safety culture and daily practices. And then there are 4 case studies on the following 4 slides that I'm going to ask you to just quickly go glance over. Maybe if I remember, if I use human factors and set up a reminder, I will send them out or send them to Kristen and Debbie to send out. So you be right before the next one. So you start to think through and let's, kind of get primed for the conversation. And you'll see we have lots of things to talk about, things that were missed, different types of situations. They're all clinical ones. And I want to be sure that we also realize that the reason for RCA doesn't always have to be some sort of clinical thing that happened to a patient. There can be all kinds of other reasons for it too, that resulted in something that wasn't safe. So that is it for me today. There's a couple of links for you in the chat that Kristen put in here too. So to get your CE units for today, there's 1.5 for today and 1.5 for next time. You'll need to complete the evaluation. So there's the link there. And if you need assistance too to set up a new account for it, there's also instructions for setting up the account too. So this is fabulous. So thank you so much, everyone. I am so thrilled that you joined us today. Is there anything that we didn't cover today that you have questions about? Anything that you wanted to ask before we sign off for today? Great. All right. Well, thank you so much. You'll also have my contact information, my colleague Jen Wagner's contact information. We'll go out with the slides and recording. Please feel free if there's something you're just not comfortable asking out loud with other groups, ask us individually. We're thrilled to talk about this. So thank you so much. And thank you what you do every day to make care as safe as it can. I cannot thank you enough for it. Have a great day.
Thank you. Thanks, Kim, Jennifer. Thanks, everyone. We'll see you in a few weeks.